So the repair of the medial meniscus tear is the one for the bucket handle tear. So we know that how it's important is to restore the medial meniscus in avoiding the contact stress and low transmissions, and it just has stabilizes to keep it the knee instability. So in 1982, in the early stages itself only, they have noticed that how if you just do the meniscectomy, there is chances of getting laxity of the knee, though you do a ACL reconstruction. Then why we do the meniscus the excisions? It has been reported in the US. You say that 9:1. They used to do the meniscectomy versus the repair. And earlier they were thinking that the repairs were not so easy, and getting it it's not easy to the healing also will be difficult. In early days, in 2001, the Moon cohort study, they showed that the 31% of medial repairs the heal, that is repaired, and versus 53% was resected. Still, repairs are less compared to the meniscectomy. So as we go right now in the state now in the 2000, see the journals 2023 and 21 and all, there are a lot of reports are saying that the repairs are very much healing potential than this meniscectomy. And there were a lot of skeptical about whether what type of equipment we should use. It was the costliest and sufficient skills do we need it to get into it, and competitive. And that is how it extends in the beginning. If you do not get into this, the meniscus, so completely it goes into coming to the notch. And that is how we see in an MRI, that's double PCL sign and shows that bucket tear is there. And you see that the world gives a little tips of how the repair has to be there. Carefully, just to have the portals is very important, especially when you are doing it in the first time. And then if you need it, you can use an accessory portals. The lateral allotted portals cannulas you can use to reduce that cartilage damage, which is important because sometimes when there is a knee is very tight, you might not be able to reach to the posterior part of a medial meniscus. So might need a little bit of medial pie crusting. So once if you have to stabilize the medial meniscus, the fragment to the capsule, and you can put a stable one stitch to the attachment to the capsule. It can be the inside out repair type of technique. And then you can stick on to the whether it is all inside technique or to the inside out technique, and it's your easiest one. So one of the technique which I'm showing over here is how the flip meniscus is there here, and you have to reduce it first one. And when you reduce it, you can see that how it goes inside. And when you're reducing it, you can feel the meniscus structure. It is sometimes, if it is very hard, it might be a chronic one. If it is very slips, goes inside, it's an acute one. So you have got an ease of repairing it with an inside out technique. Here, I am just showing it how the inside out technique only we are doing it. To reach the inside, that is the every specific the zones you have got a cannulas where you can reduce the cost. Sometimes you might be feeling that the repairing might really be very costly. So always there is a cannulas available here. You can reach out even the posterior. Only the direction has to be changed away from the midline. So when you get into it, you can repair see very perfectly the meniscus. Another one which I'm showing you is the outside in technique here. Yeah, you can see this is a very simple novel technique where you don't need any extra needles also. You can just use the simple spinal needle attached with that from the outside in. But only thing is you need to identify where you are getting into it. So before getting it, because too much of puncturing can also damage the medial collateral ligament. So be precise in where you're putting into it, gentle, and get into the part where you're repairing it about it. So once if you're done with the inside part, the outside towards the periphery, you can come down using the Prolene, and then tunneling with the suture which you are going to it. So and that is how stabilized. So they have success of this medial, that is neglected medial buccal tear is 70 to 80%. So it means that we have still enough time to repair any of the medial meniscus rather than excising it out. And what is the failure rate? You can see that failure rate is 29.3%. That is still, if we compare to the success rate and the healing and the failure rate, we have enough chances of time to take the time to repair the medial meniscus. And there are a lot of things that are, as I said, all inside. You can do it, compare if you have got enough, the time cost. And inside out technique is still a golden standard compared to the all other techniques. And when you have got a constraint with this, you can combine with the hybrid technique as well as with the uh, uh, other techniques, all inside technique. So how many the sutures we may have to use it? They says that at least a 2 to 5 millimeter of an interval should be used when you're repairing from the medial meniscus from the posterior horn to the anterior horn. And there is Sentinka et al. It was in 2021. We have showed that out of 26 patients, after 6 months follow-up, the clinical healing rate. That is, what is clinical healing rate? Just many people will be difficult about it. When you do the squatting, the patient do not have any pain. That means that the healing is very much potentially nice. So that healing rate is 77%. And radiologically, it's seen that 80% of the meniscus has been healed. That is, you will not show the meniscus, that is MRI immediately at 6 months. You should do the meniscus MRI, the new MRI post at least 1 to 1.5 years post surgery. That shows that, the 80% of the meniscus has been getting. So what are the factors which we have to use it? Because when you're doing it alone, the medial meniscus alone, you need to add some factors to the hasten the healing robots. So you can use a Trifine, you can do an hyaluron injections about it, you can do the bone marrow aspirates, you can do marrow stimulation, that is especially in the intercondylar area, and sometimes we can give the fibrin clot also and platelet-rich plasma. So all factors definitely hastens your medial meniscus repair. So what is take-home message which I'm going to give it? It is restore the biomechanics rather than excising it about it. And you got it all inside or inside out technique which you can use it. But when you're constrained, you can seek whichever technique which you're going to use inside out technique. And healing factors has a very good role when you're repairing the biomedical, medial meniscus tear. And success rate is at 70 to 80%. At the outset, I would like to invite you all for the ISCON 2024, which is happening first time in Bangalore. That is in 12th to 14th September. Many international faculties have agreed already. That is to be on the give a feast for you. So here is one of the Professor Ranbir Singh from Thailand, from New Zealand, Daniel Moya. He has got so much of this knowledge about to be shared within our faculties, and Nick Van Dong for the ankle. So we have got for the hip, wrist, everything we are including it. I'm not going to do too detailed about it. And one more, we have got is Sang Jin. So he is a very good hair as well as the shoulder and the knee surgeon. So I would like to invite you everybody so to register very early so that you can save much money from your side. Thank you very much.
Thank you, Dr. Jagadish.